I'm going to share my screen. All right. Can everybody see my slides?
You look great. Just do the presentation mode. Perfect. Thank you.
All right. Thank you, everybody, for joining in. Today's topic is infectious disease considerations and management of a chronic foot wound. I'm one of the infectious disease providers at UPMC, and we do tend to see a lot of these cases. So I'm happy to discuss this topic today. Starting off with the case, so this is 60-year-old male presenting with diabetes. As you can see, it's uncontrolled diabetes with A1C of 8, neuropathy, chronic right foot wound. Does receive regular wound care, but there's a concern for increased drainage, and the wound has been there for about a year. So he gets admitted because of a fall, no issues related to the wound, but he had no fevers, no chills, some chronic right foot pain. The reason that ID evaluated inpatient was because there was an X-ray finding that showed active osteomyelitis in the right toe distal phalanx. And as you can see in the labs, there was elevated ESR and CRP. Our podiatry colleagues evaluated the patient, and they described a full thickness ulceration on the plantar aspect of the right great toe with large amount of necrotic tissue. There was slough, but there was no purulence. There was mild erythema and edema, and no evidence of ascending cellulitis or lymphangitis. There was excisional debridement that was performed at bedsides, and there were no cultures available for review. So the questions to consider in this case, what is driving the chronic wound in this particular patient? Why do chronic wounds have slough and malodor? And does that point to needing antibiotic treatment always? Does the presence of osteomyelitis always warrant antibiotic use? So I always like to start with basic definitions. Chronic wound is a wound that is physiologically impaired due to disruption in the wound healing cycle. There's always a chronic low-level inflammation that's going on in the wound, and it basically damages the extracellular matrix, so the wound cannot completely heal. An acute wound infection basically involves invasion of a viable wound tissue with metabolically active microorganisms like bacteria or fungi that trigger a host inflammatory response, as opposed to a chronic wound infection where there's this unclear, prolonged condition, and biofilms tend to play a pretty big role in these infections. The bacterial infection impacts wound healing in multiple processes. It basically impacts almost every stage of wound healing. First of all, they produce inflammatory mediators that inhibit the inflammatory phase of wound healing, and they prevent epithelialization. But then there's a vicious circle that forms where there's infection leading to cellular death, leading to more necrotic tissue, causing more bacterial proliferation and worsening infection. So this is a circuitous process. Whenever we evaluate a patient with wound infection, we're always trying to decide in our mind what are the factors that's putting this particular patient at risk for wound infection. So there's host factors, there's wound factors, and there's factors related to the pathogen itself. In terms of host factors, we are all fairly good at identifying risk factors like immunosuppression, old age, obesity, and we've talked extensively about peripheral arterial disease, venous insufficiency, and diabetes in our previous lectures here that attribute to this risk. In terms of the wound environment itself, wound care, wound management, outpatient plays a big role, but there's presence of hardware or presence of necrotic tissue is a very big factor that we consider that attributes to the infection risk in these patients. In terms of the microorganism, there's a lot that goes into assessing the quantity of the microorganisms as to how many colony forming units there are, whether the virulence of the pathogen, the antimicrobial resistance, presence of anaerobic infection, and presence of biofilm. Those are all things we consider when we're making antibiotic decisions. So each pathology has a unique characteristic as to why it predisposes somebody. For example, in a diabetic foot wound, it's not just a neuropathy, it's also the fact that the hyperglycemia causes neutrophilic dysfunction, which impairs the ability for us to clear infections. And then there's associated arterial disease, so the blood flow is impaired. As opposed to an arterial ulcer, again, there's decreased blood flow and there's ischemic tissue, but there may not be neutrophilic dysfunction over there as what is seen in diabetes. In venous ulcer, we may have good arterial supply, but then there's increased vascular congestion, and there's a moist wound bed, which facilitates bacterial growth. And in pressure ulcer, it's more related to skin necrosis than the necrotic tissue itself getting infected with the bacterial pathogens. There's clinical impact of infection, and then there's clinical spectrum of infection. In terms of the impact, it not only has impaired wound healing, but it has localized symptoms. Patients can complain of pain, foul-smelling discharge, or it can progress to form more systemic symptoms like sepsis, physiology, and shock, and eventually leading to amputation or loss of limb. But in terms of the spectrum of wound infections, we try to classify patients based on where do they lie in terms of the clinical presentation. Are we dealing with just colonization, or is there localized cellulitis and abscess? Or is there more of an invasive spread, which can present as lymphangitis, progressing to necrotizing infection? And then lastly, if there's osteomyelitis. And the reason we try to classify which spectrum the patient lies in is because it impacts our decision-making in terms of management, antibiotics, surgical interventions, everything. So before I move on, I wanted to talk about the concept of biofilm, since it plays such an important role in chronic wounds. What is a biofilm? It's basically a form of bacterial existence that involving the aggregation and attachment of bacterial cells to a surface, followed by formation of a self-produced extracellular matrix. Think of it like a shield that for the bacteria to grow. And if you look at these images on the left, you can see that under the electron microscopic view, biofilms can be really thick. Only 6% of acute wounds will have biofilm, whereas about 60% of chronic wounds tend to have biofilms. So why am I talking about it? Why does it make treating wound infections difficult? First of all, it's literally a shield. It's dense matrix that prevents large antibodies, including antibiotics, to enter the bacteria, where the bacteria is hidden. So we basically need antibiotics that are going to penetrate biofilms. And that's why there's a lot of talk of using rifampin, which is considered as an antibiotic that can penetrate biofilms. It basically works at a DNA polymerase level, and that's why it is able to penetrate better than most of the other antibiotics. This is an interesting concept about what does the shield do to the bacteria that is underneath it. So for any antibiotic to work and be bactericidal, you need the bacteria to be replicating. So you need them to be in an active stage of replication. Once they're under this biofilm, the bacteria tend to go into what we call a dormant phase, and they have low metabolic activity. So when we use antibiotics, instead of actually being effective, because of the dormant phase and the low metabolic activity, the bacteria tend to get resistant to the antibiotics. That's why in biofilm management, debridement actually plays a better role than antibiotics because of the penetration and the pharmacological effect that the antibiotics will have on the bacteria. And then lastly, this shield also prevents oxygen diffusion to the center of the wound, which creates a lot of anaerobic environment, and hence there's a lot of anaerobic growth in the center of these biofilms, which attributes to what we see as malodor on clinical assessment. So if we go back to the questions we asked in our first case, what is driving chronic wound in this patient? It's likely the diabetes and the biofilm production. Why do chronic wounds have slough and malodor, and do they need antibiotics? We kind of answered that about the anaerobic growth. And if there's no systemic signs of symptoms, debridement may be enough, and we may not need to go towards antibiotics in this setting. And does the presence of osteomyelitis warrant antibiotic use? So in this case, it's important to define if this is acute osteomyelitis or is this chronic osteomyelitis. Now, if the wound has been there for 1 year, and if there's been bone exposure, or if it's probed to bone for 3 to 4 months with that, we may be dealing with chronic osteomyelitis. And even though the X-ray now identified osteomyelitis, it may be because this is the first X-ray we've had in 3 months to see that if there's osteomyelitis there. With chronic osteomyelitis, antibiotics are typically indicated if there's associated skin and soft tissue infection. If there's pus, if there's purulence, if there's systemic signs of symptoms, then sure, we absolutely need to use antibiotics. But the concept is that we are using the antibiotics to target the skin and soft tissue infection, not the chronic osteo, because we don't expect the osteo to heal with antibiotics alone until the time the wound is still open. So in this particular case, when the evaluation was made, it was decided to hold off antibiotics given that there was no skin and soft tissue infection identified. So and I apologize for the picture right now, it was challenging to get this picture in patient, but this same patient presents 3 weeks after the debridement that was done. But now there's fever, there's increased drainage and purulence, there's increased leukocytosis. The X-ray is now showing progressive osteomyelitis. So we asked for ABIs, and the ABIs showed mild arterial insufficiency on the right, but adequate toe pressures. So the questions to consider is, does this patient need inpatient versus outpatient management? Do we do surgical versus conservative approach, or are oral antibiotics enough, or have we come into the realm of IV antibiotics here? This leads us to a diagnosis of infection. So we all are very familiar with clinical appearance, and we've touched on this already, and the clinical spectrum that we can recognize from just a localized infection to an invasive infection. In terms of lab work, leukocytosis always points towards a systemic infection. But if patients have had ongoing intermittent antibiotic exposures, we really can't rely on leukocytosis a whole lot. And the same goes for ESR-CRP. It's helpful when it's high, but in a chronic inflammatory state, like chronic wounds are, you can almost always have elevated ESR-CRP with or without infection. So it has to be taken more as a trend rather than a spot event. I think, to me personally, clinical experience, trumps laboratory data when I'm looking at the wound. Although sometimes I do trend the ESR-CRP to see clinical improvement. Radiological appearance. So it can be hard to differentiate between acute and chronic osteomyelitis unless and until we have comparative images, and which can tell us the progression of osteomyelitis. Like in this case, we could compare the 2 X-rays and see that even in a matter of 3 weeks, there was progression of infection and progression of osteomyelitis. What we look for when we are evaluating soft tissue infection is mostly abscesses or evidence of gas or necrotizing infection that would be more urgent in terms of a surgical approach that we have to consider. And then lastly, culture data. And this is challenging to interpret unless and until we can get deep culture data. Superficial cultures can be highly unreliable, and I'll give you an example of this patient. It was a 64-year-old male with peripheral neuropathy. unclear etiology, has had chronic lymphedema and right toe osteo, has had INDs in the past, who presented with a chronic non-healing wound on two bilateral feet. And you can look at the exudates that on the wound itself. And in discussions with our teams in the hospital, there was a concern that if we did do biopsy or IR-guided biopsy of this wound, it will not heal. It'll add to the problem, so it will be difficult to get deep cultures. And a superficial culture was sent out, which, as you can see, is showing 3 different bacteria. Now, I won't go into too much details of these bacteria. Enterococcus is a fecal flora. It lives, it's not a skin flora. It's mostly a fecal flora, but it is a gram-positive organism that can be associated with wound infections. But Stenotrophomonas, the one in the middle, is actually a highly resistant gram-negative that is associated a lot more with healthcare-acquired infections, and it's known to cause biofilm formation and known to cause, to line airways or line trachs or line hardwares. So when we saw this in the superficial culture, I really couldn't tell if this is just a wound colonization, given the extensive exposure that this patient has had to healthcare, versus whether is this the pathogen that's truly causing the osteomyelitis deeper in the tissue. We tried to give him Bactrim for this treatment. He developed an allergic reaction, and then I reached out to the vascular surgeon and I pleaded for getting me a bone sample that would be more helpful. So he reevaluated the case and he took the patient for amputation. And this is what the deep wound culture showed us. Completely different pathogens except for the enterococcus. But you can tell that if we had gone just with the superficial culture, we would have missed Pseudomonas, we would have missed this highly resistant Klebsiella, ESBL Klebsiella that this patient has, which would not have responded to the antibiotics that this patient was initially on, which was Unison and Bactrim. So I just wanted to pick up this case to illustrate how different bacterial growth in a biofilm, which I think this was, which was, Stenotrophomonas probably formed a biofilm. This growth was very different from what was actually in the bones. And that's why we rely a lot more on the deeper cultures to make our long-term antibiotic plans. The questions that come up in chronic wound infections, to piggyback on the questions I asked earlier, is which patients can be treated outpatient with oral antibiotics, and which ones do we need to admit for IV? What are the most common pathogens that are implicated in chronic wound infections? I wanted to touch on what the current IDSA recommendations are and in the role of treating colonization and biofilms. Most of our data on chronic wounds actually comes from diabetic foot wounds, and we extrapolate this data to arterial wounds and wounds related to venous insufficiency and other pathologies. They're classified as mild, moderate, and severe. As you can see, mild is defined as erythema less than 2 centimeters beyond the ulcer margin with just localized symptoms. Moderate involves a more extensive or invasive infection associated with soft tissue infections like abscess, deep soft skeletal involvement, or both. And in severe cases, we are talking about systemic complications like sepsis, bacteremias, invasive osteomyelitis, extensive osteomyelitis. And why is it important? Because we can kind of make an assessment of which patients can get oral versus IV antibiotics. Can you see my full screen, or is the last side of the column, the screen, hidden? You can still see the full screen, right?
You see route and duration. Is there another?
No. Yeah, there's duration. Can you see the duration?
Yes.
Okay, because I can't see it and I just wanted to make sure. This is available in this IDSA document, which I'll give you a link of in the next slide. But when we're dealing with the mild infection, remember less than 2 centimeters, just localized symptoms, we can typically go with oral antibiotics, and the duration can be up to 7 to 10 days to 2 weeks. In moderate to severe, though, while we could end the course with oral antibiotics. A lot of us would start with IV antibiotics because we're already entering the realm where the infection is now going into deeper structures with which require more of an IV antibiotic upfront and a more prolonged duration for up to 4 weeks. And then we go into a whole different category of bone and joint infections. Now, and in that, there are various stages and various aspects. If there's bone infection, but it's completely resected, the infected bone is out, we have complete source control. So while initially we would have started with IV, we can give a very short course with oral antibiotics to finish because we know that the proximal margins are healthy and the wound is healing. Whereas when we have no surgery or dead bone, which is not getting resected, even though the route is treated as initial IV into oral, most of us will probably treat these patients with IV antibiotics for the full duration of 6 weeks. And that's why we have tried to classify which stage our skin infection is at so that we can plan our route and duration based on that. So going back to this case, vascular surgery team evaluated this patient. He went in for a staged amputation and closure, and the OR cultures drew Staph aureus, which is methicillin susceptible. So in this, the question came up, now that we have source control, do we still need IV antibiotics on this patient? And if not, what oral antibiotics could we use to complete the treatment? So to touch on the bacteriology of chronic wounds, mostly it's gram-positive skin flora, Staph aureus being absolutely the most common and also the most notorious for forming biofilms. And it can be methicillin susceptible or methicillin resistant based on what prevalence we have in our communities. This is followed by coagulase negative staph, again, skin flora, which is commonly seen in these wounds, and then beta hemolytic strep. When it comes down to gram negatives, while we can see E. coli, Klebsiella, regular Enterobacteriaceae infect wounds because of water and soil contamination, Pseudomonas is something we see when patients have had extensive healthcare exposure or they've had a lot of antibiotic exposure, which selectively leads to pseudomonal growth in these wounds. But once it grows, because of the ability of Pseudomonas to form biofilm, it tends to stay. So that's why whenever we look at these cultures and we know in the past patient has ever had Pseudomonas growth, we do worry about Pseudomonas causing recurrent infections. We already touched on why anaerobic bacteria play a role here. This is a busy slide, and I'm not going to go over every alphabet on this. But what I wanted to show you was the 2023, this is the 2023 IDSA guidelines, and they're available on this link. But if you're ever wondering which spectrum your patient lies in terms of infection severity, and if you're considering whether you could use oral antibiotics and what oral antibiotics, this document could give you some guidance on what to use. But having said that, the one thing that from an ID perspective, we've actually gone away from is using clindamycin a lot in the community. And while I was myself reading through this document, I realized that they do mention clindamycin use in patients with beta-lactam allergy. But we've seen so much resistance to strep and to staph with clindamycin that we tend to shy away from clindamycin use as our first-line agent. Typically, we'll go for something like Bactrim or Doxy or fluoroquinolone. And when we're very worried about MRSA, again, fluoroquinolone would not be a go-to. They're better anti-MRSA drugs like Bactrim, and I'm going to touch on those oral antibiotics in a bit. But apart from those little bit nuances, which the ID team might be a little bit more well-versed with, this is actually a good document to guide what antibiotic can target, what severity of infection. And this is the link to it, but it's freely available to anybody. You just have to put an IDSA wound infection, and it should take you to a link like that. So, but what do we? IV antibiotics are typically very straightforward for us to decide because of the severity of infection. But when it comes down to oral antibiotics, there's a lot more thought that goes into oral antibiotic use. So we not only have to consider the oral bioavailability, which is in layman terms, when you take a pill, how much of that pill gets absorbed into the bloodstream and reach a level in the bloodstream that's enough to overcome the minimal inhibitory concentration of the pathogen. So when we look at MICs, if you're looking like at MRSA and we see that the MIC is greater than something, let's say 10 for Bactrim, and it's intermediate, and you're using Bactrim for somebody, even if Bactrim is 100% orally bioavailable, you don't know if the Bactrim concentration in the blood is going to be enough to overcome that MIC that MRSA strain needs to be killed. So it's bioavailability, MIC, and then what are we trying to treat? Where does this drug need to go? Does it need to reach the skin? Does it need to reach the bone? That makes the whole difference. Because for skin, you don't need that much drug concentration to get there. But for bone, which are way harder to treat and much longer to treat, you need a lot more drug concentration to get there. So, and then lastly, is the source controlled, or if it's not controlled? If it's controlled, you have better chances with oral antibiotics for things to go right, versus if not controlled, there's a high chance of failure. So these are all things we think about when we are picking our oral agents. In this case, we followed the recommendation of treating upfront with IV antibiotics while this patient was in the hospital. But when he was ready for discharge, he was discharged on 2 oral agents, doxycycline and cefadroxil. Now, these are nuances that the ID team will do. Some people may have chosen a single agent. Some people choose a double agent to provide adequate bone penetration in this case, which we were fairly confident that doxycycline would provide. When we talk about which antibiotics have good oral availability based on pathogen, in terms of MRSA, the MRSA-directed therapies typically include doxy, Bactrim, and linezolid, out of which doxy has the best safety profile. Bactrim and linezolid can be difficult for long-term use. Linezolid specifically, very difficult to use beyond 2 to 3 weeks because of extensive cytopenias and side effect profile. In terms of non-pseudomonal gram-negatives, we, again, Bactrim, Augmentin, fluoroquinolones. Fluoroquinolones have 100% oral bioavailability. So they get it, and they get in very well in bone tissues. So bone and skin. So that's why they are used very frequently, but there has been a lot of resistance because of extensive fluoroquinolone use. And we try to save fluoroquinolones as much as possible because these are our only agents that are available orally against Pseudomonas. There's no other oral agent against Pseudomonas, and that's why if there's a gram-negative for which I can use Bactrim or Augmentin, I would rather do that than use my fluoroquinolones and generate resistance against fluoroquinolones. Good thing about the anaerobic cover is that metronidazole, which is our go-to for anaerobic cover, has 100% oral bioavailability. So we can be rest assured that when we use metronidazole, we can get it into most of the tissues, including bone, very, very well. While we talk about oral antibiotics, I wanted to touch on Oviva trial, which was the oral versus intravenous antibiotic use. And this trial was published in 2019, and it kind of gave us a lot of validation for using oral antibiotics, but I just wanted to talk about some of the key points. So it was a non-inferiority study that compared oral to IV antibiotics. It was done in 26 UK centers and in patients with bone and joint infections. So key is that all patients received first 7 days as IV antibiotics. And the 7 days were counted from the time of surgery, if the patient had surgery, or the first 7 days of IV antibiotics in non-operative patients. And then after that, they were randomized to either an IV antibiotic arm or an oral antibiotic arm. They evaluated about 1,000 patients. They had endpoint data available for about 1,000 patients. And you can see the treatment failure occurred roughly in 14.6% in the IV arm and 13.2% in the oral group. And the results in the summation was that oral antibiotic therapy was non-inferior to IV antibiotic therapy when used during the first 6 weeks of complex orthopedic assessment. And the treatment failure was assessed for 1 year. But if you look at the supplementary index, which is I just wanted to point out was this study was catered more towards hip, knee, basically joint infections. There were 20% foot infections that were noticed, but they didn't really differentiate between the kind of foot infections or whether they were peripheral vascular. There was no assessment of peripheral arterial or vascular disease or venous insufficiency, and it wasn't even listed in patient characteristics. If you look at the most common antibiotic used, and I'm focusing on oral, you can see that the quinolones were the most commonly used antibiotic over here in the PO group, obviously, because the IV group was more cephalosporins. And this was followed by tetracyclines, which is doxycycline, and then clindamycin. There was no Bactrim, there was very little linezolid, and almost 30% of patients had rifampin use in this study. And this is because of the biofilm concept that we talked about earlier. There was 37% staph aureus, but only 9.7% of MRSA cases were it. So UK must not have a MRSA problem, because we certainly do. But this was surprising to all of us when we were reviewing this study, that UK must be doing something right, that they don't have MRSA. And they had very few patients with IV drug use. And like I mentioned, there was no assessment on vascular interventions of peripheral arterial disease. So I think this was a very important study from an ID perspective to show non-inferiority, but I also just want to be cautious about how we interpret this study in the subset of patients where we have arterial disease, we have diabetic foot wounds, because I don't know how much of representation of those patients was there in this study. Just a quick word of colonization and biofilm management. When we have a greater than 10 to the power 5 of colony forming units as bacterial growth in a culture, it's considered significant. But if there's no sign of infection, that basically represents colonization of the wound. And the standard of care for treatment for colonization and biofilm is regular wound care with debridements. And for all the reasons that we've talked about and mentioned earlier, there's no real benefit of using systemic antibiotics to treat colonization. There were theoretical considerations for topical antibiotics, antiseptics, and dressings. And these theoretical considerations have merit that, if we use something that delivers a very high antibiotic concentration at the site of infection, could we help reduce the bacterial burden and help reduce the chronic inflammation while avoiding systemic side effects from antibiotic use? So because these theoretical considerations, they have a lot of studies that have been done. So what does the current data suggest? This was a Cochrane database review that was published in 2017, and it included about 22 trials with 2,300 participants. And they were looking at topic antimicrobial agents for foot ulcers in patients with diabetes. So what conclusions that they had was that if there were few small, very poorly designed trials, they couldn't really give any assessments on outcome of infection prevention or infection treatment. But they did say that there's low certainty evidence that use of an antimicrobial dressing instead of a non-antimicrobial dressing may increase the number of diabetic foot ulcers healed over a medium-term follow-up period. It's fairly non-specific, and it really, all it said at the end was that we need better controlled trials. So based on this, IDSA does not recommend topical antimicrobial agents specifically to be used. Basically, we don't have enough data to suggest that they are going to help prevent or treat infections. And the same thing with the wound care database for diabetes. They asked a question that in patients with diabetes-related foot ulcers, are these dressings more effective than standard of care? And when they talk about standard of care, they talk about basic wound care and debridements. And they looked at 12 studies, 5 of which actually used silver-impregnated dressings and 2 used gentamicin-based dressings. And again, the conclusion was that they were all inconsistent data with low quality evidence, and hence it was not recommended. So with that, I'm just going to come to my take-home points that what I want us to remember is biofilm formation plays a key role in chronic wound infections, and why it impacts our antibiotic choices and the way we manage wounds is important to understand. And antibiotic choices need to be made taking into consideration wound severity, pathogen identification, bioavailability, and the vascular supply to the wound. And despite theoretical advantages, currently there's no quality evidence that exists to confirm the benefit of antimicrobial impregnated dressings over usual standard of care. And that's it. Thank you. And I'm happy to take questions. And I'm going to stop sharing so that.
Excellent. Thank you so very much, Dr. Nariel. Really appreciate that, and just appreciate all the work every one of you guys do. So does anybody have any comments or questions regarding the presentation or else?
Well, I wanted to thank Dr. Nariel so much for her presentation. And I'm going to encourage all of our providers on this call to think about whatever patient they have in their mind that they've just taken care of, that they're wondering about on antibiotics, because she's here to answer these questions. There was a couple of comments. One is if you can email or share that link with the ECHO people for the IDSA guidelines,
Sure.
we could send them as an email to the group, which I think people would find helpful. And then I had a few questions. One is, and this is certainly a cultural thing, I think, at the institution that you're at. And I think things are going to shift where we are. But we did have a chief of ID for a very long time who seems like she believed that you could not cure osteo unless you amputated. And I would love to hear comments on that.
So it depends. There's hematogenous osteo without wound breakdown, and then there's chronic osteo associated with a chronic wound. And those are 2 separate, distinct categories. Acute osteomyelitis, where it's from a hematogenous source that it's gone and seeded the bone, we deal with all the time, like with MSSA, MRSA, all these gram negatives can cause it, and we treat it all the time, and they do get cured all the time. I think when there is an open wound, which allows for constant bacterial entry into the bone, that's where antibiotics alone don't make a difference. And that's where we enter into a chronic osteomyelitis realm. And sometimes chronic osteomyelitis does not need treatment at all. Like I mentioned, it basically needs wound care and treatment of the skin and soft tissue infection. But those are the cases where if the wound is so macerated and infected that it's going to keep causing ongoing bacterial infection without taking out the whole tissue and closing it, the osteomyelitis doesn't tend to heal or doesn't tend to get better with antibiotics alone.
Is this something that we can debride? Like if it's a chronic wound, could we just be debriding it in clinic and then trying to just get to healthy tissue, coupling that with antibiotics? Would you even do that? Would you wait until you got to more of an acute phase or a debrided phase before even offering antibiotics if it's just a chronic wound?
No, we do this all the time. So let's say we determine that the vascular supply is good, that the wound has good potential to heal. We've achieved the most basic source control in the OR with debridement and taking care of most of the necrotic tissue in the OR. And what we're left with is healthy tissue with a good vascular supply and a potential to heal. Then we would treat the osteomyelitis, give it like 6 weeks of treatment, and see during that 6 weeks of treatment if the wound itself heals. Because there's no point in healing the bone if the wound doesn't heal, because it's going to get reinfected. And that's where we are focused on. So to me, it's not about that the osteo won't heal. We can probably control any osteomyelitis with antibiotics. The question is whether it's going to recur and if it's going to persist despite antibiotics. But we have given it a chance and seen, and if at the end of 6 weeks, we still have persistent osteo or like symptomatic osteomyelitis, despite and an open wound that keeps getting infected, then we kind of know we've reached the threshold of where we've tried. And at that point, short of amputation, there's not much we can do.
Do you like it? Like, do you want us to close tissue over that after we've debrided it, kind of getting it to the best situation?
We typically leave that decision up to the surgeons who are actually evaluating the wound in the OR, because sometimes wound wax and healing, intentional healing actually works better than trying to close, because if you try to close and there's still infection in there, it tends to build up and the wound doesn't heal, the incision doesn't close. So that part we typically, if there's a lot of pus or if there is still wet to dry dressings that need to be done, we typically let that happen. I don't think closing the wound makes a difference. The wound healing makes the difference.
I think one thing to add to that is that there's certainly a difference in native tissue versus scar tissue that can develop when closing a wound. You lose a lot of the hydration of the tissue when you're closing wounds primarily like that, rather than having them heal through native tissue. So there's studies that show that a lot of times it just reopens. And sometimes what are you closing over too? Kind of to add to your point.
Yeah. And let's say, the surgeons tell me that, oh, we're planning grafting of the wound to close, right? And I know that there's underlying osteo underneath it. What I would do would be actually treat, if there is plan for grafting, I would always treat that osteo, because I don't want that graft to go into an area where there's high microbial burden. And again, as I stressed, you can give all the antibiotics that you want, but if there's biofilm in there that's not getting debrided or getting taken care of with wound care, the antibiotics won't penetrate and they won't decrease the microbial load. So the grafting will go on a layer of biofilm, which basically fails the graft, because then it now gets inoculated with bacteria.
So from the podiatry colleagues, are you biopsying wounds before you graft them, just to see the burden, the microbial burden?
Not routinely, but typically with my grafting, it's I kind of follow her testament in the sense that I'm not typically grafting over a lot of chronic osteomyelitis or acute osteomyelitis. It's usually just wound bed preparation in a normal fashion in terms of debridement and then grafting overlying that. I'm sure there's probably some way to begin starting it, but then the other argument too is that is it superficial culture versus biofilm kind of burden too? So am I treating just superficial stuff in that regard, kind of to her point?
Yeah, I think clinical appearance of the wound, and if there's no slough and it's healthy, I agree. Doing a soup, every wound is going to have a positive bacterial growth. So it's going to be very hard to interpret the growth in an isolated fashion. And that's why some of these wounds, once I see these patients, when I'm seeing them in follow-up, let's say that osteo is treated and the wound is doing well, it's healing, but it's just not there yet where it's completely closed up. I sometimes put these patients on oral suppression therapy just to reduce that bacterial burden, provided they're getting good wound care. Because if they're not getting good wound care, then that biofilm will happen and the oral antibiotic that I'm using is just going to get resistant and I'm going to lose that antibiotic. So typically those decisions are made in conjunction with ongoing wound care. And after some time, when I start seeing healthy granulation tissue, I just know antibiotics have no role. Even if there's superficial culture that's positive. Now what you're depending on is the skin's own potential to heal, really.
Sometimes the biggest resistance is a superficial culture, because then a patient finds out, they're like, they told me I have staph in my wound. I'm like, yeah, well, yes and no. And holy cow.
Yeah, to add to Dr. Hurst's comments about, I'm pretty aggressive about, I don't put any graft on top of anything that could potentially be infected. I do it all in the OR. I use an ultrasonic device to make sure that whatever I have is absolutely about as clean as it's going to get. And then I'm pretty aggressive about getting clear bone margins. So if there is a thought that there might be some residual, usually I'm not doing a graft per se. I do like to use native tissue, as Dr. Hurst had also talked, because I think you're going to have a much more robust closure. And I'm usually, excising out any scar tissue because it's not very vascular. It tends to fall apart. But I'd rather do probably a plastic flap versus a split thickness skin graft, because you're just going to end up with a much more robust closure.
Dr. Noriel, what is the framework of how your patients are seen in your clinic? So if we're talking about patients that are being seen in a very rural primary care office, when do they kind of get pitched over to ID? Is that even something that they could do? I don't know how realistic that is. So what can our providers be doing to manage patients that maybe have a chronic wound?
Yeah, I think a lot of the times we get referrals from our podiatry colleagues in the community when they've kind of tried 1 or 2 bouts of antibiotics, and people have had like recurrent issues with infection. And unfortunately, a lot of the times when I see them, they've already developed resistance to the oral antibiotics, and that's when they get referred to us, because now they're run out of oral antibiotic options to treat. And those can be then, we're already reaching a very challenging level of management then, because you're now going into the realm of IV antibiotics and amputations and surgeries. But it is hard. Obviously, I mean, I can tell ID access can be hard in communities. Like UPMC has this big ID Connect program. So we do a lot of telemedicine visits in which patients don't actually have to come to Pittsburgh. So a lot of my visits actually happen over televisit, and the family just trying to manipulate the camera so I can see the wound, and in conjunction with wound care notes being sent to us. So even if we can't see the wound, we know that patients have been going to wound care and how the wound is healing. So we manage a lot of these patients remotely. I may have like a few patients who are local in Pittsburgh who might come to our clinic for in-person visit, but UPMC has a very wide network with ID Connect, and that's why we're able to capture a lot of these patients and help manage them. And then those patients tend to come to us early, like because we've seen them in the hospital for some reason, or the community physicians can then refer to us for a televisit program.
Dr. Noriel, can I ask you a question? What are your thoughts about some of the newer antibiotics that are like a one-time infusion or a very short course that tend to be a lot more broad spectrum, and there's some anecdotal evidence of osteo coverage?
Yeah. You're talking about dalbavancin and oritavancin, and
Yeah.
So IDSA, the latest ID, so dalbavancin came into limelight because of its use in vertebral osteomyelitis, and because it's a longer infusion, it's a 1-week infusion. So we infuse patients once and they don't need to come for daily infusions, or they don't need to take daily antibiotics. And you can do it as 1 infusion or 2 infusions or 3 infusions. And there's definitely data to suggest that these medications have good anti-Staph aureus activity. We have used it for gram-positive infections like with strep and staph. The most of the data comes from staph, and particularly from MRSA. We have not yet had, I run we run the endocarditis service in the hospital, and I can extrapolate it from that we do use a lot of dalbavancin in an outpatient setting. We, especially in patients where, we're going to have trouble with them adhering to oral antibiotics, we tend to use this as a one-time infusion to at least give them some coverage. We know that dalbavancin gets very well into the bones. It gets very well into skin and soft tissue. And I think it could be a more utilized option. But remember, it only has gram-positive cover. It does not have any kind of gram-negative or anaerobic cover. So while if you're trying to treat just MSSA, MRSA, it might be helpful. But in most of our diabetic foot infections, which are polymicrobial, it may only solve half the problem for us. It's not been incorporated in part of the guidelines yet, but I envision that might happen in the future. And a lot of the ID providers are actually doing it in any case for some of our patients because of the vertebral osteomyelitis data that we already have.
I'm going to ask our primary providers, what is your go-to agent? Patient comes in with like mild infection, foot infection.
You're asking the primary providers, right?
Yes, I'm asking Kayla and Kristen.
Application for Medicare buy-in. Say, can you repeat your question? I have somebody talking beside me.
What is your go-to agent? So if someone comes in and they have like a mild infection on their foot, there's someone who has diabetes and they have, some redness or something, or, a small wound and some infection around it. What do you usually start them on?
I will usually do like Augmentin or Bactrim or
I usually do Bactrim.
Yeah. Usually those top three.
Is there concern for like kidney function with Bactrim?
Yeah, typically Bactrim in patients who have CKD and diabetes, I take a pause in using Bactrim because for MRSA, you need basically a higher dose. You need 2 double-strand BID, and sometimes that causes more hyperkalemia and renal issues. One thing I always like to mention is that remember Doxy and Bactrim do not have a good strep cover. They have a great staph cover. They have excellent MRSA cover, but they don't cover strep very well. So if you're seeing a lot of lymphangitis or, if patients have acute cellulitic appearance, typically it could be strep. And strep covers very well with Augmentin or cephalexin or some of your oral cephalosporins. So what I do sometimes when I see diabetic wounds, I give them a combination of, let's say, Doxy and cephalexin or Doxy and Augmentin. And that way I know I'm getting my good strep cover. With Augmentin, I'm getting anaerobic cover. And with Doxy, I'm getting good staph cover, MRSA cover, basically. And that for an outpatient, like a 5 to 7 day course for a mild cellulitis should be enough. Again, it's purulent, and this is about diabetic foot wounds. You can definitely just go with monotherapy with Bactrim and see if the wound improves, and if it improves, great. But if it's not improving, sometimes I wonder if it's because of a strep issue.
I don't think I've even thought about strep for that.
But group A strep is a very common necrotizing infection, right? So it's a common skin problem. Beta hemolytic streps are very common to cause cellulitis. In fact, for non-purulent cellulitis, the treatment of choice is always amoxicillin and cephalexin. And the reason is because of strep cover. For purulent cellulitis, it's more MRSA cover. And that's when we start adding Doxy and Bactrim and things like that.
So if there's pus, then you're going with your Doxies and your MRSA coverage. But if it's just red and swollen, then we're going with,
Strep and MSSA. Because Amox and cephaloxin still have very good MSSA cover, they just don't have MRSA cover.
So you're saying Kevlex and Augmentin for that, or?
No, I mean Augmentin only for like if I need gram-negative cover for diabetic foot wounds. But if you're talking about just simple cellulitis in a patient who doesn't have diabetes, you would only use cephalexin or amoxicillin. You don't need the anaerobic cover.
Great. Anybody else have any further questions? I know that our providers just hopped off to go to another meeting. I did want to point out, we had talked about adding more primary care providers to this so that there could be more cases and more conversation at the primary care level, because I know that we tend to geek out on the specialists on the group tend to geek out about some of these details. So because we only have a few more sessions left, we're not going to do it this year, but if we, do want to continue with the ECHO for, next year, we'll definitely be opening this up across the state so that you'll have lots of primary care providers that will be on board. Does anyone else have any questions?
Scarlett, did you have a question? Okay, no worries. I saw you show up, so I want to make sure. Well, thank you very much, Dr. Nariel, again, and thank you, Dr. Mintz. And yeah, if you do open it up, that'd be excellent. I think having more individuals will really liven it up and having more of that. So I really appreciate that comment. We hope to continue with you guys. Well, the next time we do meet is going to be April 16th, and the topic's complex limb reconstructions, amputation planning, and level with Addison Michael and Jennifer Michael. So we look forward to seeing you, and have a great rest of your week. Bye-bye.
Thank you.
you.